Good. Well, good afternoon, everybody. I hope that you're able to hear me. So I'm really grateful to the college and the team for inviting me to give this presentation on infertility. As stated in the kind introduction, I'm a consultant in clinical biochemistry based in Bristol in the southwest of England. And like most laboratory services, we provide support to endocrinologists and gynecologists and others dealing with infertility. We're a fairly large laboratory serving both the local community and the teaching hospital in the centre of Bristol and linked with Bristol University. So we have a fairly broad practice in my lab. My own clinical experience is largely in lipids and nutrition. So this morning I've been doing a lipid clinic in outpatients here. And I'm a member of our multidisciplinary clinical nutrition team here in Bristol. I have an interest in endocrinology and in diabetes in particular, but infertility, I have to say, I hope that you'll learn as much as I have learned as I've been preparing this presentation. So I look forward to going through it with you. And when we get to the end, we'll have some questions to help us to reflect on what we've learned, and some time for some questions and answers. So my aims in this talk are really going to be to give a general overview and introduction to the topic of infertility. And then we're going to hone down in particular on some of its endocrine aspects, and in particular anovulatory infertility causes in females. And then if there's time at the end, we'll go on to talk about the very general principles in the management of infertility. So I'm going to try to share my screen now, and then we'll get going. Okay, so just before I get started, is it possible for somebody just to tell me that you're able to see my first slide here, so that we know the technology
We can see it perfectly, Andrew. Thank you.
Thank you very much indeed. Okay, so first of all, just sort of to put this into context, how do we define infertility? Well, a general definition is that it's no pregnancy after 12 months of regular, unprotected sexual intercourse. And it is a really common issue. There have been a range of estimates. Probably around 10% of heterosexual couples worldwide experience some difficulty with infertility. Possibly as many as 20% of women in the USA aged between 15 and 49. And as you might expect, perhaps, the prevalence tends to increase with age. And it is has a really significant impact on patients' lives and patients' health. And this is underlined by the fact that the World Health Organization has formally designated it as a disease. So here are just a few little vignettes of how people feel about their infertility. So I'll just read through some of these just to give us a context. So when we started trying, just a few of our friends had children. But by the time we were doing IVF, everyone had them. It wasn't as bad for my husband, but I felt really excluded because all the other women were talking about things I didn't know about, and going to places you couldn't go without a baby. Every day I go to work in fear of an announcement. I struggle seeing people in the street who are pregnant. I have to not even look at them. I feel like it's turning me into a really horrible person. Although my brain knows it's not my fault, my heart still says that I've failed. I know it's not true, but a woman who can have children seems a better woman in some way than I am. So clearly this has a really profound impact on the lives of patients and of couples. In terms of the causes, we're going to focus largely on females, but if you just look at the pie chart at the top of my slide here, first of all, you'll notice that in fact it's fairly equally distributed into female causes and male causes, or where there may be factors from both parties. So it's really important not to consider that infertility is a female problem. It is a male and a female issue. When we look at the different causes that are present in females and males, there are some interesting differences. And in particular, you'll notice that in females, the largest group of causes is the ovulatory disorders. So those are the ones we're going to focus on this afternoon: endocrine causes and other metabolic causes of ovarian dysfunction. Followed with mechanical causes, tubal and peritoneal disease, uterine or cervical problems, and a few are unexplained. When we move to males, on the other hand, there are quite a lot where there's no obvious explanation, and then there are these more anatomical causes like consequences of urogenital infection, undescended testes, and only a relatively small number are of a more clearly metabolic or endocrine cause causing hypogonadism. I think it's probably a good idea if we just remind ourselves about the underlying physiology before we get going, although we won't focus too heavily on this. So you'll remember the hypothalamic pituitary gonadal axis in females, hypothalamus producing GnRH in a pulsatile fashion that stimulates the anterior pituitary to produce FSH and LH. Those are dual trophic factor in play here, FSH and LH. LH acting predominantly in the ovaries on the thecal cells, generating androgens. FSH acting primarily on the granulosa cells, and in particular stimulating the development of the oocytes. The androgens produced by the thecal cells are then taken, or some of them are converted by the granulosa cells around the oocytes to convert from androgens to estrogen. And that tissue also produces inhibin, which has a negative feedback effect on FSH production by the pituitary. If we come on to looking at the menstrual cycle, it's probably easiest if we sort of start following through this towards the end of the luteal phase. In the absence of pregnancy, the corpus luteum is involuting, the suppressive stimulus on FSH is diminishing, FSH levels begin to rise, and this initiates the development of a small number of primordial follicles each month into these larger so-called antral follicles. And this is stimulated by FSH. Those follicles, the granulosa cells around those follicles produces estradiol, and those estrogens then gradually suppress the FSH. Most of those preantral follicles involute and disappear as we reach mid-cycle until a single antral follicle becomes dominant, and the large surge in estrogen production from around that antral follicle drives by positive feedback the LH surge that occurs in mid-cycle, which initiates ovulation. The corpus luteum then stimulates progesterone that initially sustains the endometrium for implantation of the corpus, and if pregnancy hasn't occurred, after a few days that the corpus luteum begins to involute and the whole process of the cycle begins again. So we're going to move now into talking about the causes of female infertility. And as I said, we're going to focus largely on ovulatory dysfunction. And rather conveniently, the WHO has classified ovulatory dysfunction into 3 groups. Hypogonadotrophic hypogonadism, where there's low gonadotrophins and low estradiol, and we'll look at these causes again in a moment. Group 2 being polycystic ovarian syndrome, which we'll spend some time exploring, with typical findings of relatively unremarkable FSH, raised levels of LH quite often, but not invariably, and a well estrogenized patients with relatively normal or slightly high estrogen levels. And then group 3, hypergonadotrophic hypogonadism, the easiest to remember form, or the commonest form perhaps, being primary ovarian insufficiency or ovarian failure, but there are some other causes of ovarian dysgenesis or ovarian dysfunction that again we'll mention. I find it quite useful to add to this list hyperprolactinemic anovulation, particularly in response to a prolactinoma. This isn't formally part of the WHO classification, but it's another cause of ovarian dysfunction. Before we get stuck into looking at each of those 3 causes, however, let's just think a little bit more about the tests that we do to tell us whether ovulation has occurred. In other words, that a normal menstrual cycle is underway. And I think we're all very familiar with the use of mid-luteal phase progesterone as the test for ovulation. A few things to say about mid-luteal progesterone. Of course, the cycle isn't always regular and isn't always 28 days. So a low value could be due to a mistimed sample, particularly if the cycle length is difficult to predict. So conventionally, we say day 21 progesterone, but ideally it needs to be 7 days before the next menses. And that 21-day figure may need to be modified, for example, if we know that a particular woman has a shorter or a longer cycle. And some people even advocate testing 2 or 3 times during the luteal phase to hit that sort of mid-luteal phase, or that isn't something that we routinely recommend. Conventionally, we consider progesterone greater than 30 to suggest ovulation. And one often wonders, well, what if it's clearly risen, but it hasn't reached 30? Some people sort of term that as being indicating suboptimal endometrial function. But I think that more likely levels that are raised but not reaching the 30 nanomole per litre threshold probably indicate mistiming of the sample. So early on or late on during that progesterone rise that occurs if ovulation has happened. It's worth remembering that up to 25% of cycles are anovulatory, even in normal women. So it's usually worth checking a 21-day progesterone at least twice before making a decision that ovulation isn't happening. On the other hand, if a woman's having a regular cycle to within a day or 2, particularly if it has a fairly normal cycle length, it's pretty likely from a clinical perspective that ovulation is happening. There are other ways of determining ovulation. Cervical mucus thickens and thins, and at around the time of ovulation, the cervical mucus thins out, and that has been used in the past. More relevantly, perhaps, there is a significant rise in basal body temperature that occurs around ovulation. And some women keep temperature charts to enable them to detect that and also to determine the time of ovulation, the timing of ovulation, in order to predict the most likely time of the month when intercourse would result in conception. Unfortunately, my bottom line seems to have dropped off the slide, but there are also point-of-care testing assays for urinary LH, urinary luteinizing hormone, which have been advocated and used, particularly again to assess the most fertile time of the menstrual cycle in order to time intercourse, particularly around those periods where pregnancy is proving difficult to establish. Although I think that's rather a stressful process for all concerned, and it hasn't really entered very common usage, at least in the UK. So, moving back to our WHO causes for ovarian dysfunction. And the first group of causes is the hypogonadotrophic hypogonadal causes. And we'll just briefly take a look at those. So I've just given us a short clinical vignette of a typical case. So this is Sarah, who's a 23-year-old research student who's in training with the university athletics team. She spends 2 hours each day in the gym. She's always been at quite a low weight, but she's lost another 5 kilos in the last 3 months, and currently has a BMI of 17.5, so that's low. She's not had a period for 6 months, and they were previously very light and irregular. And there aren't really any prizes for interpreting these data appropriately, so she's got a combination of low LH and FSH with a low estradiol, indicating that this is likely to be of central origin, hypothalamic or pituitary. We've checked her prolactin and her TSH because those are appropriate investigations in any patient with amenorrhea or with an irregular menstrual cycle, and they're both normal. So, as we said on our previous slide, common causes of hypogonadotrophic hypogonadism very much include low body mass index, anorexia, excessive exercise, and hyper-trained, very highly trained athletes, female athletes, very often experience amenorrhea, probably not only as a consequence of their low body weight, because they're not all of low body weight, but also the stress of the intense training regimens that they undertake. Kalman syndrome is an inherited disorder of hypothalamic pituitary underdevelopment, together with olfactory dysfunction, so there is no sense of smell. And some of you may remember that Sheehan syndrome occurs as a result of infarction of the pituitary, usually shortly after delivery if there's a lot of blood loss. And so women who suffer Sheehan syndrome, amongst other things, may be unable to re-establish a normal menstrual cycle after they finish breastfeeding. So the diagnosis of this particular cause depends on, first of all, the presence of amenorrhea, be it primary or secondary. Really useful, as in all cases, really to take a detailed medical history about the patient's lifestyle, any previous illnesses, what's the sense of smell, etc. Demonstrate that low FSH and LH and low estradiol. And as I've said, prolactin and TSH are indicated here, but they would tend to be normal if it were due to hypogonadotrophic hypogonadism, or perhaps slightly raised if there's a stress response that could put the prolactin up a bit, of course. I suppose we should perhaps just consider that if the patient has panhypopituitarism, they might also have secondary hypothyroidism, not a topic for today's discussion, but you'll remember that secondary hypothyroidism is characterized by a low T4 but a low normal TSH. Then they're not well estrogenized, So there isn't a large uterine endometrium, and so after a progesterone challenge, there isn't a withdrawal bleed. Relatively uncommon as a cause of anovulatory infertility, but probably accounts for about 10% of anovulatory cases. Treatment, well, weight gain and other support to achieve and maintain a normal body weight is often sufficient to restore normal ovarian function and enable a pregnancy to occur. But if it's an intrinsic hypothalamic cause like Kalman or Sheehan syndrome, then some of the standard forms of artificial fertility techniques are valuable. So pulsatile GnRH, if it's available, it's not routinely available in all parts of the world, or daily injections with LH and FSH, usually derived from menopausal female urine, to trigger development of the oocytes, monitored carefully with ultrasound, and then once an appropriate stage of maturation has been reached, injection of HCG as a substitute for LH to trigger ovulation. So artificial fertilization techniques are certainly available and can achieve a successful pregnancy in these hypergonadotrophic group of patients. I'm sorry that we're really unable to address questions as we go along and that I'm simply having to talk, but do jot down any points that you'd like to go back over afterwards. I'm very happy to take them and go through them. Okay, so what about group 2? So this is polycystic ovarian syndrome. We all come across results from patients with PCOS on an almost daily basis, don't we, in our laboratory-based practice. In terms of the basic biochemistry, often characterized in terms of estrogens and gonadotrophins by normal FSH, sometimes a raised LH, but not invariably, and usually the estradiol is normal. It may be slightly raised, and there are abnormalities in androgens that we'll come on to in a minute. So here's Martha, who's 26, came off the pill 2 years ago because she and her husband wanted to start a family. Her periods have since become irregular, and sometimes she doesn't have one for 2 to 3 months. She's embarrassed also by acne on her face. On examination, she was overweight. She had a BMI of 28.2, and there was increased hair noted on her upper lip. A blood sample was taken on day 3 of the next cycle, and you'll notice that she has a relatively high LH, which is actually almost 3 times the FSH. She has a high normal testosterone, but a total testosterone that is nevertheless within the reference range for this particular assay. That would be the reference range for our current Beckman assay that we have here in Bristol. But she has a low sex hormone binding globulin, with the result that her free androgen index, a marker of her free testosterone status, is significantly raised. Although the total is normal, the binding protein is very low, so the free testosterone is raised as expressed in females by the free androgen index, which is the ratio of total testosterone to SHBG. In fact, about 65% of testosterone is bound to SHBG, and there are a number of important factors that are relevant to PCOS that will cause those binding globulin levels to decrease. In particular, increasing androgen levels decrease binding SHBG levels, and conversely, an increase in estrogens will increase SHBG levels. Furthermore, SHBG is very sensitive to insulin responsiveness and insulin resistance. So patients with insulin resistance or obesity will have low levels of SHBG. There are some other causes, hypothyroidism and glucocorticoid therapy, principal amongst them. But this dual effect of two factors that are often present in polycystic ovarian syndrome, I think underline the reason why SHBG levels are such a useful marker as part of the biochemical workup of PCOS. Patients very often have both increased androgen activity and an element of obesity or insulin resistance. Now, both estradiol and testosterone bind to SHBG, but testosterone binds more strongly. So this graph over here, which is taken from Marshall's textbook, illustrates the effect of falling levels of SHBG on the percentage of free hormone. And you can see that the percentage of free testosterone rises disproportionately more than the percentage of free estradiol as the SHBG level falls, reflecting this stronger binding of testosterone than estradiol to SHBG. So, to put it in a different way, as SHBG levels decline to low levels, there is a relative preponderance in increase of free androgens as opposed to increase of free estrogens. So we have both an overall reduction in increase in free testo and an increase in the testosterone to estradiol ratio. You'll perhaps know that in men, we tend to estimate bioavailable or free testosterone through a calculation involving the Vermeulen equation and SHBG and albumin. But in females, the preferred estimate of free testosterone levels is the free androgen index, I think primarily for the reasons that I've just illustrated here. Typical symptomatology of PCOS, in particular, weight gain, difficulty in losing weight, irregular menstrual cycles, signs of androgen excess, acne, hair loss, excess body hair, excess terminal hair, and some other gynecological symptoms. Pelvic pain and ovarian cysts are observed in ultrasound, of course. The definition that is now used, I think fairly universally worldwide, is the Rotterdam 2003 criteria, which actually stipulate the need to have the presence of a minimum of 2 out of 3 criteria. Those criteria being oligo or amenorrhea, clinical or biochemical hyperandrogenism, and polycystic ovaries on ultrasound. And this probably doesn't come out terribly well depending on the size of your computer screen. But you can probably make out this ring of follicles around the outside of this ovary on ultrasound, the so-called ring of pearls sign, apparently. Typical finding in polycystic ovaries as well. But I'd stress that just the finding of polycystic ovaries on ultrasound doesn't mean that a woman has polycystic ovarian syndrome. She has to meet at least one of these other criteria. And of course, it's important to consider and exclude other causes of hyperandrogenism or so-called PCOS symptoms, things that can mimic Cushing's syndrome, particularly because there is some androgenic activity of the glucocorticoids, and sometimes the ovarian tissue can also overproduce androgens. Late onset congenital adrenal hyperplasia, a lecture topic all of its own, but that partial 21-hydroxylase deficiency biochemically picked up by measuring the precursor to that enzyme, 17-hydroxyprogesterone, either as a random sample or after synacthin stimulation. Adrenal or ovarian tumours can, of course, produce androgens as a tumour product, and DHAS, if present, would point more specifically towards an adrenal cause rather than an ovarian source. What's the key defining criteria for tumours producing excess androgens compared with PCOS? Just think for a moment. That group of patients, of course, are likely to have suppressed gonadotrophins rather than the raised LH levels that are characteristic of PCOS. Hypothyroidism can mask. Prolactinoma, well, could cause menstrual irregularity, and it's worth actually just bearing in mind something that I didn't know until I looked into this topic recently, that prolactin levels are very commonly mildly elevated in PCOS. I haven't seen the mechanism for that, but something like a third to a half of patients with PCOS actually have slightly raised prolactin concentrations. Now, what is the etiology of polycystic ovarian syndrome? Well, I have to disappoint you by saying that you will find as many different explanations as books and review papers that you will read on this topic. It's really difficult, and I think we don't fully understand what the primary and what the secondary changes are. But suffice it to say that I think the most common single unifying factor that is always present is an increase in testosterone production by the ovary. It isn't a monogenic disorder. A single gene has not been found. It is likely that there is some genetic predisposition, perhaps a range of genetic polymorphisms involved in androgen synthesis or in follicular genesis, which at the time, particularly of puberty, when these pathways are stimulated, results in tonic overproduction of androgens by the ovaries, by the granulosa tissue in the ovaries. That tonic overproduction of testosterone results in the maturation, then premature arresting of the maturation of a group of primordial follicles, resulting in that polycystic pattern that we saw. But they then fail to involute, and we don't get the development of a single dominant follicle at around the time of ovulation. So if you like, there's an arrested maturation of follicles, and all those follicles will tend to be producing increasing amounts of androgen. So there's a sort of a cycle there. Excuse me. That tonic increase in testosterone also actually drives LH production by the pituitary. And that will feed back and further promote androgen production. There is probably also some sort of feedback right to the hypothalamus, because people have found a change in the pulsatility of GnRH production, which modifies the behavior of the pituitary in favor of producing LH rather more than FSH, so perhaps explaining that relative preponderance of LH that occurs in PCOS. But then the other side to the coin is that these changes are very often exacerbated by the presence of insulin resistance and obesity. So if a patient is predisposed to diabetes, if they become obese, even if they're not predisposed to diabetes, they will develop insulin resistance. And so there are environmental and genetic factors there as well. And for example, we know that PCOS is more common in the daughters of type 2 diabetic men. So there is definitely an inherited element there as well, determining insulin resistance, as well as an inherited element determining androgen production. It's not a single disease, hence the name syndrome. It's a collection of issues. And I quite like this figure that I found in a Nature review of endocrinology, which sort of points out that there is a continuum. There will be some women who have predominantly a particularly severe abnormality in androgen secretion. And that group of women, even in the absence of any insulin resistance or obesity, may develop PCOS. It's not just obese women who develop PCOS. At the other end of the spectrum, there will be women who've got predominantly those insulin-resistant features and only minor abnormalities of androgen production. But all of these types will develop, could develop polycystic ovarian syndrome if there is that balance of those two factors. The final definition that I particularly liked when I came across it was from 2015, which said there is generally poor understanding of its etiology. I think we're probably closer than we were 25, 30 years ago, but I think we also acknowledge our lack of understanding rather more honestly than we did at that time as well. How do we manage it? Well, lifestyle factors to optimize insulin sensitivity, healthy diet, exercise, achieving an appropriate body weight. Metformin is sometimes used even in the absence of frank type 2 diabetes. It obviously is the main initial stay of the treatment of type 2 in particular. The standard forms of artificial fertility treatment with HMG again for stimulating ovulation, suppression of that LH drive with the estrogen partial agonist antagonist clomiphene, or even letrozole, which is an estrogen antagonist that is more commonly used as hormonal treatment for breast cancer, can be used to suppress that abnormal pituitary stimulus. Interestingly, ablation of some of the granulosa cells, the granulosa tissue in the affected ovaries can also restore more normal ovarian function with diathermy ablation through a laparoscope. Okay, so that's polycystic ovarian syndrome. Happy to answer any further questions on that when we get to the end. The third group, hypergonadotrophic hypogonadism. So if you like, primary ovarian failure. We'll look at some causes for this in a little more detail in a moment, but it includes primary ovarian insufficiency, chromosomal issues like Turner syndrome, or inherited disorders like 46SY gonadal dysgenesis. So here's a couple in their early 30s who've been trying unsuccessfully for 2 years for pregnancy. They were seen together in the clinic, which is always good practice. Each had a child by a previous marriage, so they'd previously both parented a child. And the male partner had a normal sperm count. There was no evidence of any issue with the male partner. Interestingly, 3 years previously, the female partner had developed adrenal failure, for which she was on steroid replacement, and her periods had become irregular. Whoops. So what do we notice here? Take a look at those data. It's such a shame that we're not all sitting around a table in a seminar room when this is the time when I can really ask you what you think in your interpretation. But nevertheless, here we are across the airwaves. So you'll notice that she has a raised FSH with a smaller elevation, but nevertheless a high level of LH with a low estradiol. She had a normal prolactin and a normal TSH, excluding those two as issues. And this turned out to be autoimmune ovarian failure. She'd already developed autoimmune adrenal failure, and it turned out that this patient was developing pluriglandular syndrome or generalized autoimmune pathology, so that at the age of 30 she'd undergone a premature menopause, if you like, owing to autoantibodies to her ovarian tissue. So here are some of those causes of hypergonadotrophic hypergonadism. X chromosome abnormalities, as you said, like Turner syndrome, so a karyotype is useful. Fragile X syndrome. Swyer syndrome, 46XY, so normal chromosome count, but complete gonadal dysgenesis, so phenotypically female, due to a due to a genetic mutation for a factor that determines differentiation into the male phenotype during early fetal maturation. And then primary ovarian insufficiency. Sometimes it's idiopathic. Don't forget that female babies are born with their entire lifetime complement of primordial follicles in their ovaries. And those are gradually expended during post-pubertal life until the menopause, when there are no more. If somebody is born with a low number of follicles, then they will run out more quickly, to put it very simply. Autoimmune, chemotherapy or radiotherapy, ovarian preservation of oocytes is sometimes practiced. Stimulation and then extraction and freezing of oocytes is sometimes appropriate in women who are going to undergo chemotherapy or radiotherapy, so they can subsequently have a child by artificial fertilization. There are a few inherited metabolic disorders. The one I think you should remember is galactosemia, where there is replacement of normal ovarian tissue. Smoking damages the ovaries, as do other toxins. And then we come on to hyperprolactinemia. Estradiol's likely to be low. Gonadotropins are usually unremarkable. Let's talk a little bit more about prolactin. So we're all familiar with the mechanisms of prolactin. Prolactin, as you can see on the picture on the left, actions principally physiologically on lactation in the breast. It feeds back. Well, no, before we get to feedback, let's do feed forward. So its tonic production is normally under inhibition by dopamine, and there is also some stimulation from TRH. So you can see that on here. Feedback inhibition, to complete a negative feedback cycle, occurs to the level of the hypothalamus. A third action of prolactin that is perhaps less well appreciated is that it blocks the action of gonadotropins on the ovaries or the testis. So that's probably one of the principal mechanisms by which it causes infertility. Although, of course, a large prolactinoma would also destroy normal gonadotrophic cell activity within the pituitary gland. I'm not going to talk at great length about prolactinoma. It's a topic, again, all of its own. Don't forget that a small rise in prolactin is much more likely to be a stress response. It should be repeated. We always check for macroprolactin in any patient with a raised prolactin. So we're looking for those large macromolecular aggregates that occur in some patients that impair prolactin clearance, but are not necessarily bioactive and don't reflect increased prolactin production. As we said, about 15% of women with PCOS have hyperprolactinemia. We would recommend referring on and considering for imaging if the prolactin is consistently greater than 1,000 million international units per litre in the absence of other causes. And those other causes are hopefully well known to everyone. So there's that stress thing. Drugs, particularly antipsychotics, atypical antipsychotics, as well as the more traditional antipsychotics, risperidone, haloperidol, quetiapine, aripiprazole, etc., can all cause very large prolactin-raising effects, even to the extent of causing galactorrhea. Less commonly used dopamine-depleting agents like methyl-dopa. High doses of estrogens will put up prolactin levels. Then there's pituitary disease. If there is a significantly raised prolactin of less than 5,000, it's usually a microadenoma. A greater than 5,000 might well be a much larger tumour, a macroprolactinoma. And other pituitary tumours, which of course could bisect the stalk and cut off that dopamine inhibition and therefore allow increased prolactin production. Hypothyroidism by its effect on TRH and chronic kidney disease. Okay, so how do we assess a woman's ovarian reserve? Well, we could attempt to do this as perhaps was practiced at one time by measuring some of the driving or feedback hormones, so FSH or inhibin B. These are not very good markers of ovarian reserve. They tend to be very variable. More commonly now, the gynecologists will actually image the ovaries and count the number of antral follicles that are present. And it's fair to say that, in fact, at a population level, the best predictor of ovarian reserve, the number of follicles that are still there, is the patient's age, or the decline with age. But we need to understand anti-Müllerian hormone, which is the best biochemical marker of ovarian reserve. So it's a dimeric glycoprotein of the TGF-beta superfamily. It's responsible in fetal life for apoptosis of the Müllerian ducts during male embryogenesis, produced by growing follicles, probably has a role in regulating ovarian function, doesn't fluctuate during the menstrual cycle, and low levels indicate depleted number of remaining follicles. So here's an example of AMH being used. So 38-year-old woman attended the clinic with her partner. They'd been trying to conceive for the last 2 years. She had a regular cycle, treated hypothyroidism, didn't smoke, didn't drink alcohol. Her partner was in good health. They were both assessed as is appropriate, and in fact in the partner, semen analysis demonstrated a normal sperm count, but reduced sperm motility, which would limit the possibility for normal conception. She had a day 3 blood sample, which was unremarkable. There's no evidence that she's got ovarian failure. FSH was normal, unremarkable estradiol. This probably wasn't as necessary. With a menstrual cycle, we perhaps that was regular, wouldn't necessarily recommend doing a prolactin or a TSH because they're unlikely to be causative. Her AMH was measured on day 3, and it was 9.5 picomoles per litre. And by the assay that we use in Bristol, we reckon that a level between 6.5 and 19.8 predicts a normal response to controlled ovarian stimulation because it predicts that there are an appropriate number of antral follicles present. She had ultrasound as well, in fact, and that confirmed that there were, I can't really interpret this for you because I'm not a gynecologist, but it was interpreted as showing that she had an adequate follicle count. In other words, with insemination, she would stand a decent chance of becoming pregnant. So the conclusion from the fertility clinic was satisfactory ovarian function, normal ovarian reserve, male factor of fertility, and she was referred to the fertility service for intracytoplasmic sperm injection, which is a particular form of in vitro fertilization, where the eggs are harvested and in a petri dish they are injected intracytoplasmically with the partner's abnormally motile sperm. The sperm themselves have got the right package of DNA in them, but they can't penetrate the eggs properly. So ICSI is appropriate under those circumstances. Okay, so there's a bit of a march through some of the courses. Just finishing off with sort of bringing this back down to what do we actually do. In the UK, we have the National Institute for Health and Care Excellence that produces lots of guidelines that help us to have consistent standards of practice. This is a little bit old now, but you could find this on the net. You can find this as CG156 on the internet. Fertility problems, assessment and treatment. And I just want to go through this very quickly because it just sort of says what we've already said. It summarizes. So initial assessment of the infertile woman, age, frequency of intercourse, menstrual history, regular menstruation, light menstruation. Has she been pregnant before? That might help us to know whether there's a primary or a secondary cause. Has she been poisoning her ovaries with alcohol and smoking, or indeed use of any drugs that could be ootoxic? Is there any previous surgery that could cause either damage to the tubular system, the ovary or cervix, or indeed the ovaries themselves? Is she overweight? What's the BMI? Is she underweight? Both causes of infertility. Signs of hyperandrogenism, galactorrhea, pointing towards hyperprolactinemia. Investigations including transvaginal ultrasound of the ovaries and perhaps imaging of the system with hysterosalpingography to see whether in fact there are patent fallopian tubes that would allow normal fertilization to occur and passage of the fertilized ovum down into the uterus. We've talked about these tests: gonadotrophins, estradiol, progesterone, AMH or antral follicle count. NICE tends to be very, very miserly in the tests that it recommends, because in our National Health Service we have to constantly be saving money. But quite rightly it recommends prolactin only if there's anovulation, galactorrhea or a pituitary tumour, and TSH only if there's clinical evidence of thyroid disease. So that really only if there's other clinical pointers towards thyroid disease, it's really worth doing a TSH. And testosterone, together with SHBG and that free androgen index, if there's any clinical evidence of androgen excess. It also recommends checking chlamydia antibodies. Chlamydia infection could cause tubal blockage and tubal problems. And a general check of prenatal health, if you like, which would be relevant if the woman subsequently became pregnant. And in some cases, chromosome analysis to look for evidence of ovarian dysgenesis. In men, similar sort of assessment. How old are they? How frequently is intercourse taking place? And this is not a flippant comment, but it is important to establish that couples are appropriately trying for a pregnancy and that the frequency of intercourse is appropriate. Again, factors that could damage the ovaries or the testes or previous surgery. Examination of the external genitalia, particularly important to look for things like variceles. But the most important investigation in men is seminal fluid analysis, sperm count, sperm morphology, sperm motility. Again, some routine serology, which would be relevant particularly if artificial fertilization techniques were going to be used, and simple biochemistry tests to look for evidence of primary or secondary testicular failure. Okay, so we're nearly through. I just thought I'd like to spend just 3 slides just giving a very, very brief summary of assisted reproduction techniques. This again is very high-tech stuff, and I don't think we've got time, or indeed it's necessary for us to go through them in detail. But I wondered if this might be useful. So here's my cartoon showing the axis: hypothalamus, GnRH, pituitary, gonadotrophins, ovaries, sex hormones, with negative feedback going on. So the most commonly used forms of assisted reproduction involve 3 hormonal steps. First of all, suppression of normal pituitary gonadotrophin production, either because it was raised or just to make the response more predictable. And this is, strangely it may seem, either with a GnRH agonist or a GnRH antagonist. GnRH antagonists will just simply block the effect of GRH on the pituitary. Agonists, after an initial burst of activity, will down-regulate the receptors and again effectively reduce the GnRH stimulus. After that's in place, ovarian stimulation over a cycle of a period of days, 10 days or so, with a daily injection of gonadotrophins, subcutaneous gonadotrophins, to stimulate those primordial follicles to develop, regular ultrasound monitoring, and sometimes monitoring of LH and estradiol as well to monitor the function of the pituitary and of those developing follicles. Followed on the appropriate day by triggering ovulation, usually with subcutaneous HCG as a surrogate for LH. Has the same effect. It triggers ovulation about 2 days after the ovulation trigger is administered. Careful ultrasound monitoring, as I've said, careful monitoring of estradiol in particular, not only to check that there has been normal maturation going on, but also that the ovary hasn't been overstimulated with overproduction of large numbers of follicles, which could result in ovarian hyperstimulation syndrome, which used to be a really quite common and dangerous sequel to artificial fertilization techniques. So that's the sort of biochemical side. What actually happens next? So I quite like this very easy step-by-step guide here. So we've got that production of the eggs by hormone therapy. The eggs are then retrieved laparoscopically by the gynecologist or the obstetrician. The sperm sample is provided by the partner. They're combined in this very simplistic Petri dish here to enable fertilization to happen in vitro fertilization. That's checked, and then after it's got to, this is an 18 or 16 or 32 blastocyst stage, that fertilized egg or eggs are reimplanted back into the uterus and will implant, and normal fertilization will occur. And this is just showing the egg retrieval procedure via an aspiration needle with ultrasound guidance and a collection pump. And this is what it's all about. So this is Louise Brown, who was the world's first test tube baby, born in 1978 in Bury in northern England. Prior to that time, it was by no means certain that it would be possible to achieve in vitro fertilization. There were also, by the way, considerable ethical questions that had to be faced and moral questions that had to be faced as to whether it was appropriate to achieve a pregnancy out with the normal process of pregnancy and reproduction. But over the last 30 odd years, many millions of couples have now been helped by this and other techniques, and by our investigation, the investigations that we facilitated of their infertility. So I hope that you found that useful. We're going to stop for questions, but I think that probably it's, unless I'm told otherwise, if we go on at this point to take a look at 5 MCQs, 5 multiple choice questions that will just test our understanding of some of the material that we've delivered, and see how we get on with them. So I'm just going to move forward slightly and put up the. You need to put up the poll as well. I think that everybody can see my question now in its entirety and the poll screen. So I'll just give you the clinical scenario, which doesn't appear on the poll. So this is a 28-year-old woman consulted her doctor because she had not become pregnant in spite of trying for 18 months. She had a regular menstrual cycle with a cycle length of 28 days. Which of the following biochemical investigations would be most helpful in determining whether she was ovulating? We're moving on to question 2. Okay, so the context of question 2, you need to look at the question first of all. A 23-year-old commercial lawyer was concerned because she was unable to conceive. She had no previous pregnancies. Her periods had become light and irregular. Initial investigations showed low LH at 0.6, lowish FSH at 1.5, and an undetectable estradiol at 80 picomoles per litre. So all low, gonadotropins low, estradiol low, which is the most likely cause for her infertility. 23-year-old commercial lawyer was concerned because she was unable to conceive. She had no previous pregnancies. Her periods had become light and irregular. Initial investigations showed a low LH at 0.6, a low FSH at 1.5, and a low estradiol at less than 80 picomoles per litre. So which of the following is the most likely cause for her infertility? I'll give you 30 seconds. This is a 25-year-old woman who was overweight and had read a magazine article about polycystic ovarian syndrome. She was concerned that she might have that condition. Her doctor agreed to assess her androgen status. Which of the following androgen parameters is most commonly abnormal in PCOS? Okay, thank you. Question 4. The scenario, the STEM, is hyperprolactinemia is a relatively common finding. And then the question that you can see on your poll, which of the following is not a cause of hyperprolactinemia? Okay, and then question 5, again, don't respond until I've given you the STEM. A 42-year-old woman and her new husband consulted a fertility specialist. They were anxious to know her chances of having a child. The specialist recommended an anti-Müllerian hormone test. What is the purpose of this test? So many people have already had a go at this, but there's opportunity for those who haven't. Just in 30 seconds, just to think about that one. Okay, right. So I'm going to end the poll now, and I think we're going to have the responses displayed to us. Right, okay, let's go briefly through and see how we've done. These are pretty good responses to me. So the first one was basically which is the test for ovulation. This was a sort of fairly straightforward starter question to get everybody going. And most people have correctly defined that it's progesterone on day 21 of the cycle, if the cycle length is 28 days. If the question had been, she had a cycle length of 16 days, then of course day 21 wouldn't be appropriate. It would be day 9 of the cycle. But with a regular 28-day cycle, it's 21 days. As we now know, AMH is a test for ovarian reserve, not ovulation. FSH is a test for ovarian function, not for ovulation, and is done on day 3. Inhibin B has only very limited use now in the assessment of fertility. is used as a marker for granulosa cell tumours, by the way. And I just put in LH on day 21 just to see if anybody was awake. And that really doesn't have any significant value at all. LH values are really poorly defined in the middle of the luteal phase. So well done. 71% of people got that one absolutely right. I think it's important to remember that AMH is a test for ovarian reserve, the number of follicles sitting in the ovary available for ovulation, whereas progesterone is the test that ovulation has actually occurred in that cycle. The second one was the patient who had light irregular periods and low gonadotrophins and low estradiol. So this is hypogonadotrophic hypogonadism. And again, the largest group had it right. I think it's most likely that this was somebody who anorexia nervosa would fit with this. There are no particular pointers to Addison disease in the clinical scenario. And of course, in any case, if this were Addison disease with also autoimmune destruction of the ovaries, that would cause a raised LH and FSH below estradiol. PCOS, well, you know that you normally see raised LH levels in PCOS, so I don't think the low LH would fit there. Sheehan syndrome would do if this was a secondary problem, but this is a bit of a more difficult one. This patient hadn't had any previous pregnancies, so would be unlikely to have had that postpartum, couldn't have had postpartum pituitary hemorrhage. So that's that. And Turner syndrome would cause ovarian dysgenesis, so raised gonadotrophins. Androgen parameters, yeah, most people remember that the free androgen index is the most appropriate parameter there. As we said, you can calculate free testosterone, but that's more appropriate in men. SHBG on its own is probably the thing that's most likely to be abnormal, but is less sensitive than the index. Total testosterone levels are often within the normal range, although high within the normal range. Some people actually advocate androstenedione as a more sensitive marker of androgen status in the ovaries, but it doesn't really have routine widespread use, certainly not in the UK. Which one doesn't cause hyperprolactinemia? Well, I'm glad that hardly anybody thought that antipsychotics don't, because they're a very common cause, as we know. It's hypothyroidism that causes it, so this is right. B, hyper is not a cause. Macroprolactin, aggregating prolactin, or macroprolactinoma, a large prolactin-producing tumour, would cause hyperlactin. And as we've said, PCO, just be a little bit wary here. Some people answered PCO, but we said about 15% of patients with PCO actually have a raised prolactin. So I think that hypothyroidism was a better response. And then, this is fantastic. Look, everybody is obviously measuring AMH every day in all their patients, and is familiar that AMH is a test for ovarian reserve. So thank you all very much for participating in that, and I hope that's given a little bit of useful feedback at the end. So now I'm very happy to answer questions. So I'm going to stop sharing. I'm going to stop sharing my screen and ask if there are any questions, please. And I think somebody's going to moderate those.
Yes, perfect. Thank you, Dr. Day. That was an excellent presentation. So we actually have some questions in the chat box. Are you able to see in the chat box?
I am currently struggling with the technology. I've got it back. Here we are. Oh, good. Yeah, good. Okay. Shall I work my way through them?
Yes, that would be great. Thank you.
Okay, so first of all, and I apologise in pronouncing your names. Wally, first of all, thank you so much for your complimentary comment. I'm very grateful. I've really enjoyed putting this together. And yes, I do think that, it really is important that as clinical biochemists, we are fully keyed up to the clinical applications and relevance of what we're doing. Most of us are medically qualified and have a medical background, And it's also so much more fun if we're sort of out there talking and understanding what our other medical colleagues are doing, of course, than simply sitting in a laboratory providing interpretations and overseeing analytical output. Experience on luteal phase defect. I really know very little about that. You see people who comment on low day 21 progesterones and say a patient has evidence of luteal deficiency. I've got no experience, but as I understand it, it's women who are unable really to sustain endometrial function throughout the luteal phase, so that even if fertilization occurs, implantation is poor, and they don't get a chance to establish the rudiments of the placenta and the chorionic villi that then go on to produce the HCG and take the conceptus through the first half of pregnancy. And normogonadotrophic hypogonadism, again, I can't really comment too much on that. All I would add is that seeing normal LH and FSH with low estradiol levels is relatively common in my experience. And I think as much as anything, it reflects the relatively poor diagnostic utility of estradiol measurements, quite honestly, as it does telling us anything very specific. But you can see I'm hedging on that one a little bit. HCG challenge test still done in the evaluation of obstruction of the sperm duct in men. As far as I'm aware, we no longer do HCG stimulation tests in the investigation of male infertility, be it obstruction of sperm duct or other defects in spermatogenesis. Certainly we don't see any biochemical results coming through. If it's done as purely, and I don't think it's still done as a test for to be able to look at the sperm mobility or function. But I'm not a gynecologist, so I can't really answer that except to say that we certainly don't see any of the biochemical side of that coming through. If anybody was able to answer, I'd be interested to know whether it's still used where you are. Somebody's put their answers in. Sharifa, thank you very much. Fatima, is the progesterone assay recommended in a female with shortened and irregular menstrual cycle? Well, it remains a valuable test for observation, as I said. It can be a little bit challenging to find the mid-luteal day, as it were. Sometimes it has to be estimated, sometimes it has to be done on more than 1 month. Sometimes I've seen in books a recommendation that 2 or 3 samples are taken at daily intervals at around what you think is going to be the mid-luteal phase. But in practice, we don't tend to see that. And then, what will be the biochemical correlate of high LH with normal FSH, testosterone with LH FSH ratio greater than 2? So this is okay. So to me, that would be most likely to be polycystic ovarian syndrome. In terms of the ratio, the old textbooks used to say the LH to FSH ratio is greater than 3 in PCOS. That no longer applies and shouldn't be used as a hard and fast yardstick. And I think that, interestingly, it was more of a finding with very old non-specific LH assays. But I'm speaking 20, 30 years ago, which you don't hear me blathering on about. But a high LH with a normal FSH, and therefore a relatively high ratio, is not uncommonly found, is very often found in PCO. And as we said, the total testosterone is quite often unremarkable. And it's only when you delve a bit deeper and measure the SHBG and demonstrate that there is a low free androgen index that you actually come up with the answer. So I would say that is the most likely explanation. It would be useful to know the estradiol as well, of course, but if it was ovarian failure of any sort, I'd expect the FH to be disproportionately raised to the LH. So if the LH is relatively high in relation to the FSH, in my view, it probably is PCO until proven otherwise. And then we have a few more MCQ answers there. So I hope that's been useful in responding to the chat. Are there any verbal questions at all? Are people able to speak?
Oh, thank you very much, Dr. Bill.
Pleasure.
I wanted to ask about DHEAS.
Yes.
Or DHEA. I know it's an androgen, and at times, I don't know what his position is in PCOS. Is it, I understood the free androgen index is more contemporary in terms of PCOS. I'd like to know whether DHEAS has any role.
Yes, that's a really good question. Thank you. So DHEAS is an androgen that's produced almost entirely in the adrenals. And really very little by the ovaries. The ovaries will produce testosterone and they'll produce androstenedione. So it's not characteristically raised in PCOS and isn't generally of diagnostic use. But if you are concerned that in fact you're missing the fact that this isn't PCOS but could be autonomous production of androgens from a tumor, and you're trying to differentiate between adrenal source and ovarian source, then measurement of DHEA sulfate could add to the picture. Of course, then you tend to have suppressed gonadotrophins as well in either of those tumor causes. So it's not measured routinely in the diagnosis of PCO. It's used in that differentiation between adrenal or ovarian source for the androgens, and we measure them relatively infrequently. Androstenedione, on the other hand, as I think I said a short while ago, has been proposed as being more sensitive to mild androgen excess than is testosterone. But that hasn't really caught on either, but it sometimes adds supporting value. But DHEAS, no, it's for adrenals, to look for evidence of an adrenal source. And we do relatively few of them, I think perhaps because adrenal and ovarian imaging gets better and better, that trying to look through a glass dimly, as it were, at the androgen profile is of lesser value. That's a really good question, thank you.
Thank you, Dr. Day. We also have a question from Fatima, so I'm just going to allow them to talk. I think after that, we've got time for maybe 2 or 3 more questions, and then we'll have to shortly end the session.
Good afternoon.
Hello, good afternoon.
Thank you very much for the presentation. I actually have some questions which I have been encountering during the course of my practice. Sometimes we see cases of infertility.
Yeah.
Unfortunately, at the long run, there happen to be ambiguous genitalia presenting at adulthood. So we tend to see sometimes testosterone very high, FSH, LH all high. And in this facility, so I wanted to know, with the testosterone and FSH, LH all on the high side, what would have been our conclusion?
Gosh, that's a difficult one. Testosterone.
Female gender.
Yeah, female gender.
Somebody presumed to be a female gender, though with ambiguous genitalia, but presumed to be a female gender.
Right. Okay. That's getting a little
with
bit
elevated gonadotropins and testosterone.
Do they have 5-alpha reductase deficiency or some form of androgen insensitivity, perhaps?
Infertility.
Have you considered that? And are they completely phenotypically normal female?
Phenotypically, yes, I can say on the outside it may look, but since we just receive samples and sometimes we see the patient superficially, I don't actually have full information about the phenotypical appearance of the patient.
Yes. That would be one thing that I would want to know about, but it sounds so they may have some form of androgen resistance, perhaps.
Yeah, so Andrew, my question is, in your practice,
Yes.
What percentage of infertility is actually due to ovarian dysfunction? Because here, majority of the causes here of infertility are actually due to tubular structural dysfunction, like tubular blockage from infection. So I'm just wondering, what percentage from your
Yes.
practice of infertility is due to ovarian dysfunction? Thank you.
I don't know the answer to that, in that we've never sort of formally looked at it. What I can tell you is that we did look at I'm not sure whether you were on the call at the beginning, but we did look at some published data which seemed to show that ovulatory disorders accounted for about 40%, and that tubal problems are only around about 25%. I suspect that was probably US or UK data. And I'm sure that you're absolutely right that will vary geographically depending upon factors like health in childhood and sexual health and other factors that could affect, for example, rates of chlamydia infection, that could affect tubal patency. So and of course, I wouldn't be able to answer that question for you from a biochemistry lab perspective, because we never see the results of the hysterosalpingography or the chlamydia serology. So I'm sorry I can't give you an answer to that question, but I think you're right that it's likely to vary quite significantly in different parts of the world. Do you have any
Thank
further
you.
Do you have any further insight into that yourself? Would you think that that's likely?
Yes, just like I said, from our own local studies here,
Yeah.
we found out that ovarian dysfunction is responsible for about 19% of our cases, while about 40% of our cases
Yes.
are due to tubular structural defects,
Yes.
such as blockage from sexual aids, just like you mentioned earlier. And the chief of that is gonorrhea in this environment.
Really, yes, which is having a bit of a resurgence in the UK, but it's not that common. And the overall prevalence of infertility does vary around the world as well. And I wonder whether the absolute incidence of anovulatory infertility is the same, but you've just got a much higher prevalence in some areas of tubal blockage, sadly. Yeah, thanks.
Thank you.
Perfect. Well, great. Thank you so much, Dr. Day, for a brilliant presentation.
Thank you.